Welcome, friends. This is Dr. Jaitly from New York, your cardiologist on your favorite video site, MuniSTHealth, which is being shown on several social platforms and primarily dedicated to medical education and patient education, mainly for medical fraternity as well as to your general masses. And we help improve the clinical outcomes through this video site, which has been my global initiative and, of course, my deepest belief in the past 40 years in my practice here. So welcome again to be on MuniSTHealth. Hope everyone is healthy. Well, obviously, we certainly want to keep you guys healthy, and that's the whole idea, wanting to tell you about the health and illness together. And, primarily, obviously, cardiovascular system we are currently doing. So, essentially, without any further ado, I'd like to delve into the subject matter. The subject today is, what is athlete's heart, and is it abnormal? Now, a lot of people ask a question, oh my God, my doctor told me that I have a big heart or a hypertrophied heart, and I work out and I'm an athlete and I'm a so and so forth. Well, the heart is big in an athlete's chest. That's a given. Now, that's primarily because there is some hypertrophy. What is hypertrophy? Hypertrophy is increased muscle mass, if you will. So the muscle mass starts increasing, this being your right ventricle, it will increase here. The muscle mass will increase here, and it being the left ventricle, predominantly we are concentrating mostly on the left ventricle because that is the biggest booster chamber out of the 4 chambers here. So the athlete's heart will have hypertrophy across the board, whereas the closest differential, which is hypertrophic cardiomyopathy, that's an abnormality. Now this is abnormal, and this is normal. So a hypertrophy which could be normal present in an athlete. Now we are talking about an athlete who actually works out to train very strenuous competitive sports like marathons and trained runners or sprint runners, or if you will, the weightlifters and what have you. So we are looking at big time athletes here. So that's where they will develop this so-called athlete heart. It is still a normal variance. I call it a normal variance because there are no symptoms, obviously, in these individuals. They are not symptomatic. Whereas the hypertrophic cardiomyopathy patients, they are symptomatic. They will have chest pains, they may have breathing difficulty, they may have exertional passing out spells or syncope, we call it. And of course, they'll have heart murmurs. Now, family history will be also very prevalent in hypertrophic cardiomyopathy. Why? Because there might be some remote history of syncope or sudden cardiac death, we call it SCD. So that will be also prevalent in hypertrophic cardiomyopathy, whereas an athlete, no, there will not be any family history. So just by history alone, one can really start looking at hypertrophic cardiomyopathy versus athlete's heart and distinguish that. Now, it's very important that there is an overlap here. That's why I've shown these 2 circles to sort of overlap here, because there may be a place where hypertrophic cardiomyopathy and an athlete's heart may not be distinguishable or discernible. And as a result, one can have a little overlap, especially if athlete's heart is now just evolving or hypertrophic cardiomyopathy is also evolving in a very early stage. You may not be able to see. The concentric hypertrophy goes in favor of hypertrophic cardiomyopathy. So remember, the LVH that's present in hypertrophic cardiomyopathy is more concentric, whereas I apologize, that it's more eccentric, and LVH in the athlete's heart will be more concentric variety. So eccentric variety will be present in an hypertrophic cardiomyopathy. And why? Because you'll have a septal hypertrophy here, and that is obstructing your left ventricular outflow tract. So you'll develop a more eccentric hypertrophy in a setting of hypertrophic cardiomyopathy, HCM we call it. So HCM will have eccentric variety of LVH, if you will, because the septum is hypertrophied. In fact, the ratio has been shown to be 1.3 to 1.5 over 1.0, obviously from the free wall, when you compare these hypertrophies, and they could be easily measured on an echo in terms of centimeters or millimeters. Okay, so but the ratio will be at least 1.5 and above in order to, and it's the gray zone between 1.4, that's where the problems arise, and one may not be able to ascertain that. So if the ratio in an athlete's heart, the ratio could be still less than 1.3. And you could sort of, that's the variance, and that's the variation that's overlapping a little bit on the hypertrophic cardiomyopathy. Now, LV cavity is the key here because LV cavity is very small here. Now, you see this hypertrophy that's going in the hypertrophic cardiomyopathy in that HCM we call it, or the other name is ASH, asymmetrical hypertrophy. That speaks of it directly. So when you have ASH, what's happening is the left ventricular outflow tract is further getting buried, if you will. And as a result, each time the ventricle contracts, it further gets buried, and therefore there's a hemodynamic, exertional compromise on the outflow tract, if you will. So the outflow tract is actually suffering more here as a result each time when the ventricle contracts. So the LV cavity is smaller here. Why? Because the LV cavity will be about less than 45 millimeters in a setting of HOCM, like I've just said here. And LV cavity will be more than 55 millimeters in a setting of athlete's heart. So when you have athlete's heart, the cavity is actually larger. Why? Because the ventricles are a little bigger in these patients. That's why they have higher volumes and they have slower heart. So athletes in general have a heart rate of about 35-40, and that's pretty normal for them. Why? Because they are pushing blood in stroke volumes and not more they're more dependent on stroke volumes than on heart rate. And heart rate they will speed up when they really get to the sprint levels or when they're exercising to the max. Cardiac MR will be a very distinguishing test here, as a matter of fact. And so if the echo does not define the HOCM, or the HCM we call it, versus the athlete's heart, you could do a cardiac MRI, and that'll be a clincher here in the diagnosis, because you'll have late gadolinium enhancement, we call it LGE, and that will be present in this septal area, LGE we call it, and that's a diagnostic feature in a cardiac MR, if you will, for HOCM. It'll be present only in HOCM and not in athlete's heart. So I said negative here. Okay, and the genetic testing can be done in a sarcomere. Mutation is now, this is more of more prevalence, where you really can't even tell the cardiac MR or distinguishing features here at all. Then a genetic sarcomere mutation will be helpful, and of course the mutation will be present only in the HOCM variety and not in the athlete's heart. Sometimes in the overlap variety, it's very helpful to do a sarcomere mutation, because here you don't know which way the person is going to go. So this becomes the real, because even the cardiac MR may not be positive here yet, because it's a very early stage of athlete versus HOCM. So sarcomere mutation will be present only in HOCM. So somebody wants to ask you a question out of the entire list. What is the diagnostic way of knowing whether you're dealing with HOCM versus athletes? Well, answer is sarcomere mutation. But non-invasively, if you were to test and diagnostically be able to say for sure that LGE, the late gadolinium enhancement, will be able to define the HOCM very easily. And again, echoes are helpful, but absence of late gadolinium enhancement does not rule out HOCM. So presence will definitely confirm, but absence will not rule out. Whereas sarcomere mutation, either way, will define what's going on here, because if it's positive, you know it's HOCM. If it's negative, it's athletes. Okay. Very short video here distinguishing athlete's heart. So do not consider athlete's heart totally as abnormal. It is totally normal for that individual, and obviously it has certain distinguishing features. There may be some so-called variance in terms of abnormalities, like left ventricular hypertrophy. Sometimes the EKG is also abnormal looking. It's not normal. Obviously it has some findings like T waves will be high or more tall. Left ventricular hypertrophy patterns will be seen on an EKG, whereas on the hypertrophic cardiomyopathy you will see a pseudo-infarct, we call it, and or septal Q waves, if you will. So there will be septal Q waves, and the T's will be inverted in those individuals. So that means if you were to do lead 1 or V2, pardon me, my phone's just rang. So anyway, so that happens here. So in V1, V2, you'll have Q waves, as a matter of fact, in V1 and V2, and that will give you a clue that these are septal Q waves in the presence of hypertrophic cardiomyopathy and not in athlete's heart. Okay, whereas in athlete's heart, you'll definitely see an R wave prime there as well on the EKG. But the LV cavity size will also be a distinguishing feature on an echo, because less than 45 millimeters will go more in favor of HOCM. So this is less than 45, and this will be more than 55, because this is more LV dilatation. This is more LV hypertrophy, if you will. Okay, and of course we talked about the concentric and the eccentric variety. So stay tuned, stay well, and stay healthy, and obviously stay on MuniSTHealth, your favorite site for learning, mainly for cardiovascular education. Okay, and thank you again, and until next video, say so long to